we know that the use of dexamethasone, a glucocorticoid dexamethasone, has been promoted as a routine and important intervention in obstetric care to reduce preterm mortality and morbidity. In 2015, an important question was asked: can the benefits of glucocorticoids seen in high-resource countries be extrapolated in low-resource countries? So in 2015, Altabi et al. Published in The Lancet the trial, a population-based multifaceted strategy to implement antenatal corticosteroids treatment versus standard of care for the reduction of neonatal mortality due to preterm birth in low-income and middle-income countries, also known as the ACT cluster randomized trial. This trial was conducted in 6 countries, and their objective was to assess antenatal corticosteroids feasibility, effectiveness, and safety in low-income and middle-income countries. The primary outcome was neonatal mortality among infants less than the 5th percentile for birth weight, and this was a proxy for preterm birth. Their findings in their conclusion was that neonatal mortality did not decrease in the intervention group, and they conclude that for every 1,000 women exposed to antenatal corticosteroids, an excess of 3.5 neonatal deaths occur, and additionally, there was an increased risk of maternal mortality. So based on this result, the WHO recommended that antenatal glucocorticoids be used only under certain circumstances, such as an accurate gestational age, an imminent preterm birth, absence of maternal infection, and adequate care during delivery and for the neonate. So here we can see there is conflicted evidence between the ACT trial and the evidence that we have here in high-resource country. So several questions arise for me. First, why the conflicted difference? Could this be secondary to any system-based problems with resource, or the maternal population who is at risk of preterm birth is different? So this is the question that we're going to answer during the presentation.
So I think it's a good point for a good time for Dr. Job and Dr. Collar to provide some insight about this ACT trial and how it changed and what the scenario was at that time.
So Wally, you want to give that a go?
Yeah, I'll start. Sure. I was, in full disclosure, I was part of the investigators in that trial and designed the trial. And we thought it was a good design up front because it would be like introducing a practice that was effective. So we introduced it as in clusters. So a cluster randomized control trial. So that has a important advantages, let's say, for doing a pragmatic implementation. On the other hand, it has important research limitations. And you can see in this trial, Elena didn't review that because it's a lot of details about the trial, but there were more smaller babies in the antenatal steroid clusters.
I have a slide that compared both trials.
Oh, you will do. Okay. So
yeah, it's coming.
It's coming. Okay. So I'll just mention briefly that there were more babies exposed to antenatal steroids and more babies of smaller babies, and that accounted for about half of the mortality, those excess babies. So while the design is a good design for pragmatic trials, the cluster randomized trial design, it's not as good as an individual patient randomization. And the other problem is that as a cluster trial, we have to look at the whole cluster of all the deliveries. So if you look at that paper, it's almost 100,000 babies. So they had to follow 100,000 babies so they could follow the whole population of babies who may have not been exposed to steroids. Not everyone was exposed to steroid. So there's important limitations. So after that study was conducted, then it made sense to do an individual randomized trial to make sure the effects of steroids were beneficial.
So maybe I should just comment. Dr. Carlo was actively involved with the WHO, and when the ACT trial came out, it turned out that it was like throwing a hand grenade into the WHO, because they had just spent years working through their 2015 recommendations, with antenatal steroids being the highest priority recommendation. And that trial just screwed up everything, because that was the first evidence in low resource environments. The thing that wasn't mentioned is, which is most important, is the increased mortality was in kids that were probably term, not in the preterm infants. So this trial was truly unique in that all the babies were followed up. Virtually all the other trials that have ever been done, the only people who were ever followed up were the preterm infants, and not those that delivered at term. And now there are new data out saying that that's been a big mistake. So then I'll stop talking. So Elena, go ahead.
Okay. So now let's talk about the objective of the trial. So the objective was to assess the safety and efficacy of dexamethasone in women in hospital in low resource countries who were at risk for early preterm birth. So a first question that I want to ask is, this study address a clearly focused research questions? Yes. So if we evaluate the recent question by population, we will say that the population were women at risk of preterm birth, and the intervention was the use of dexamethasone. The comparator was the placebo, and the outcome was preterm birth. So now let's discuss the methods. So this trial was a multi-country, multi-center parallel group, double-blind, individually randomized placebo-controlled trial that compared intramuscular dexamethasone with placebo in women at risk for imminent preterm birth. The trial was conducted in 29 countries across 6 nations, and the nations were Bangladesh, India, Kenya, Nigeria, and Pakistan. The trial hospitals were selected through a standardized assessment of maternal and newborn health service to ensure that the WHO criteria for antenatal glucocorticoids treatment could be met. So each participant site had a minimum standard of quality of care. This is important. So the presence of an ultrasound from the OB side, the presence of CPAP, pulse oximeter, and the glucometer. And they also standardize the training that they provide to the clinical staff and also for the research staff. So the pregnant women who had who has a confirmed live fetuses were that were between 26 weeks and 32 weeks and 6 days of gestational, who were at risk of preterm birth, were eligible for inclusion. And the inclusion criteria was expected preterm birth in the next 48 hours. And the gestational age was determined by the earliest ultrasound examination or ultrasound at admission. Exclusion criteria were signs, maternal signs of severe infection, major congenital anomalies, the use of systemic glucocorticoids, contraindication for glucocorticoids, and participation in another trial. So the randomization and procedure, the participants were randomly assigned in a 1-to-1 ratio for a course of intramuscular dexamethasone or placebo every 12 hours for a maximum of 4 doses or until hospital discharge or birth. The women were eligible for a repeat course if they had not given birth after 7 complete days and still meet inclusion criteria. They did a site-stratified individual randomization with a balanced permuted blocks of 10 that was used, And the computer generated randomization sequencing was centrally at the WHO. So all sites, yes.
So Dr. Wally, do you and Dr. Job, you want to comment on the trial design and the randomization? And can you teach the fellows about the individual randomization with permuted blocks?
Sure. So they use large blocks, and that's good because they had few sites and a large patient population. So the number of blocks depends really on the number of patients that will be randomized by group. These were 29 hospitals, and they had they were going to enroll over 4,000 women. So they can use a large number of patients per block or randomizations per block. So a block of 10 means you take 10 ballots or 10 that say either intervention or control, and you mix them together, and then you take the next 10, you mix them together. So at any time, there's minimal imbalance between the groups randomized to control and intervention. So therefore, this is a good thing. When you have smaller blocks, there may be a problem with unmasking. For example, if you have blocks of 4 or so, and then the two kids do well, then you are expecting that the other 2 may not do so well because they may be the control group. So this is large blocks is really good. In addition, this is a placebo control, so it's going to be masking quite well.
Thank you. Dr. Joe, do you have any comments on the trial design or the selection criteria?
Well, I think it's, in fact, I think it's overstated that they randomized hospitals that had good care for the infant. It turns out that we had really this is for the ACT trial now, we really had no good estimate of gestational age, which was a major problem. And we really had no availability of CPAP or oxygen to care for these infants. So the infants had no expectation of adequate care, which was a major problem.
Thank you, Dr. Job.
That's a really good point, Alan, because the patient populations are very different. These are tertiary and secondary centers, whereas in ACT, they were typically primary centers. There may be some secondary, but mostly primary centers that did not have the resources to provide care for very premature babies.
So the ACT trial was actually an implementation trial. It wasn't a traditional drug trial. The primary question wasn't would steroids work, but could you identify these patients, get them treated, convince them to go to a higher level of care for delivery, and would that make a difference? So it's an entirely different question than the WHO trial.
Interesting. Thank you so much. Elena, you can proceed.
So just one last comment about in the randomization. The clinical care was provided through the local guidelines, and the follow-up the infant and the mother was conducted until 28 days of birth or the death of the child. So the trial outcome, the primary outcomes were neonatal death, and this was defined the death of a live-born infant within the first 28 days of life, and then then a composite neonatal death or stillbirth and maternal infection. A maternal infection was defined as maternal fever or clinical suspected or confirmed infection for which antibiotics were used. And the secondary outcome were written in the supplemental material for the neonates was the like a growth measure like birth weight, FOC, length, gestational age, duration of oxygen, duration of CPAP, duration of antibiotic, length of hospital stays, And for the mothers was number of days of antibiotics, the length of maternal hospitalization, and any maternal readmission. So for the statistical analysis, the team estimated that 6,018 women will have to be recruited to detect a decreased risk in the neonatal death of 50% or more in a two-side 5-4% significant difference with a 90% power and a 10% loss to follow up. The primary outcome was an intention to treat analysis, and their hypothesis was that the use of dexamethasone would result in a decreased risk of neonatal death and stillbirth or neonatal death without increasing risk of maternal infection. And they apply a superiority hypothesis to the neonatal death and stillbirth and a non-inferiority hypothesis for maternal infection.
So, Wally, I'd like to bring you again, if you can explain to the fellows the difference between using a superiority hypothesis versus a non-inferiority hypothesis for this trial.
Yes, so the primary outcome, the hypothesis is that neonatal mortality would decrease. Therefore, a superiority hypothesis is the best, is appropriate. They're hypothesizing that the maternal infection will not increase. So therefore, it's a non-inferiority hypothesis. So they are doing it quite well, I think.
Good. Thank you.
Okay, so let's answer, is the basic study design valid for the randomized control trial? So for this, we need to answer, was the assignment of the participant to the intervention randomized? I think we already went over this. So they describe well how the randomization was carried out to 1-to-1 ratio with the block of 10 and the benefits of the block of 10. And I think the method was appropriate, and we already discussed this. And there was the randomization sufficient to eliminate systematic bias? I think so, but I would like to hear you guys' comments about.
I think so. I think, as I mentioned, with 10 patients and then a mask randomization, I think it's likely to eliminate systemic bias. And we can see from the results that the patient populations are quite comparable, for example.
Mm-hmm. And then was the allocation sequence concealed from the investigator and participant? Yes, they were blind. And so was the study method, how the study methodology was? So were the participant blind to the intervention they were given? Yes, and also the investigators. But the personnel who analyzed the data, the outcome was not blind. So now let's talk about the results. So from December 2017 to November 2019, 7,008 women were screened for eligibility. Of those, 2,852 underwent randomization and 4,156 were excluded. And in the manuscript, they describe why they exclude those women. So so they were planning to do 3 interim analyses, but after the second interim analysis that involved 2,304 women, and with complete follow-up for the primary outcome, the data and the safety monitoring board decided to unblind the trial and recommended to stop the trial because there was a strong evidence with the primary outcome. So the recruitment was stopped in November 2019. So for the dexamethasone group, we have a population of 1,429 women, and for the placebo, we have 1,423. For the dexamethasone group, 99.9% of the moms received dexamethasone. There was only 1 patient who did not receive it. And they described in the supplement material, they did not because mom delivered the baby before receiving the medication. Loss to follow up was 8 women with 12 infants. And for the primary outcome, we had data for 1,416 women. For the placebo group, the population was 1,423 women. All the months received the placebo. They have a loss to follow-up of 9 months, and we have primary outcome data for 1,412 women.
Just to comment that it is pretty good that they had such complete or high proportion of the patients with the outcomes.
Yes.
So they had less than 1% loss to follow up. So that's exceptional. In most trials in the US, or in many trials in the US, they may have missed 10% of the participants or so to the follow-up, let's say to complete follow-up. This is to 28 days, so some of the babies will have gone home and it's hard to follow them up. So that's a pretty good follow-up rate.
So I'll just add a little political comment here. So I was at a meeting in Istanbul called by the WHO and Gates to evaluate this trial at the time of this second look at the data. And the meeting was called because the investigators were concerned that the majority of the women were delivering at less than within the first 24 hours after treatment. So they actually thought the trial was going to fail, and they were trying to figure out how to jimmy the trial so that they could get a positive result. And what they ended up doing is deciding to stop the trial. They didn't have the analysis of the outcome at that time. And so they got really lucky because they stopped the trial way early, and they still got a positive result. And that probably resulted from the good trial design. So they just got lucky because they stopped the trial early because they actually thought it was going to fail because of their early look at the women who were being enrolled and when they were delivering. So at the end of the day, it turns out they were running 2 trials in parallel. They were running this preterm trial, and they were also running a late gestation greater than 34 weeks trial. And that trial was also stopped so they could reassess that. I think it's really important to consider the fact that they did these evaluations of this trial, because this trial was very controversial because we were using a drug known to be effective, but yet we had a placebo group. And there was people who questioned the ethics of that. And so they stopped the trial very early and got a positive result so that very few women were actually put at risk who did not receive the drug. Wally, any comments?
No, I agree with you totally, Alan. And I actually was not aware that they stopped the trial first without looking at the results because the paper doesn't say it that way. But so they got lucky. But in terms of the 50% of the patients or so got the at least 1 dose. Oh no, sorry, received 50%. Over 50% received 4 doses, and so I know what happens in real life, that you're seeing too many delivering before they get the 4 doses. But we know now that even after the first dose, 6 hours later, there's already a benefit. There's some modeling that has been done in studies from France and in the US, and they show benefits as soon as the first 4 to 6 hours. So even 1 dose has been shown to be quite effective.
So if you look at their actual numbers, about 60% of their babies were delivered before 24 hours after the first dose. So most of these babies didn't get repetitive dosing like we would be doing for most of our patients in the US. That's why they were concerned it was going to be a failed trial. And so they were trying to figure out what to do about that. And they decided that the better part of valor was to stop the trial and do an analysis without knowing, they stopped the trial without knowing the results, which was the right thing to do under this circumstance.
That's some great insight. Thank you so much, Dr. Jobin. Wally. Elena, you can take over.
Okay. So, were all the participants who entered the study accounted for the conclusion? Yes. So we have 7,000 women, and if you have in the publication, we have 2,852 women underwent randomization, and 4,156 were excluded. And of those 2,000 women who underwent randomization, they explained really well, like how many were lost to follow up. And as we already discussed, they have a small rate of loss to follow up. And the participants that were, and also the question is, were the participants analyzed to the study group to which they were randomized? Yes, so every participant that were randomized to each study group were analyzed in their study group. And we already explained why the study was stopped early. And so was the clearly defined study protocol? Yes, and they explained that in the supplements. And if any additional intervention were given to the study groups, there was no additional intervention. Were the follow-ups intervals the same for each study group? Yes, every baby was followed up, and moms were followed up until 28 days of life. So this is the characteristics of the participant at the trial entry. Here the dexamethasone and the placebo, we see that 66%, around 60% were spontaneous preterm birth, 31% were premature rupture of membrane. Gestational age was around 30 weeks. The maternal age was 27 weeks. Preeclampsia was common around the 20%. And when they mean non-obstetric condition, it was just a healthy pregnancy, around 40%. So were the study groups similar at the start of the randomization control trial? Yes, they described the baseline characteristic of each study group, and I didn't see any significant difference in between study groups that could affect the outcomes. So adhering to the assigned trial regimen, I found this interesting that for the dexamethasone group, 99% of the mom received the first dose. Only one mom did not receive it, and the second course was only given to 4.3%. For the placebo, every mom received the first course, and only 5% repeat the second course. So for the primary outcome, here we have a neonatal death. There was a 19.6% of death in the dexamethasone group and 23.5% in the placebo group, with a relative risk of 0.84 and a p-value of 0.03. For stillbirth and neonatal death, we have 25% for the dexamethasone, 29% for the placebo, with a relative risk of 0.88 and p-value of 0.04. And for the possible maternal infection, remember that this outcome was a non-inferiority. So the dexamethasone, we have possible maternal infection for 4%, placebo was 6%, and our p-value was 0.02 with a non-inferiority hypothesis. And so for neonatal death, here we will see the result by a pre-specified subgroups. So for a planned preterm, we noticed that there was a decrease on neonatal mortality on the spontaneous preterm. There was a significant reduction in neonatal mortality when the gestational age was between 28 to 32 weeks. And there was a significant decrease in neonatal mortality when the first dose of dexamethasone was given more than 24 hours after birth of the neonate. And now let's discuss the result for the stillbirth or the neonatal death subgroup. Again, we can say that there was a reduction of stillbirth or neonatal death for a spontaneous preterm birth. There was a reduction of mortality in neonates with a gestational age between 28 to 32 weeks. And there was a decreased mortality when the dexamethasone was given more than 24 hours after birth.
Yeah. Wally, you want to comment on the primary outcomes in this result so far, and Dr. Chewbacca?
Yes, so it's very important that they report neonatal death. Obviously, that's the important outcome, but it's also very important that they also report stillbirth. And the reason for this is like, unlike what you all are used to, stillbirth can be quite common in some environments in low resource settings. And for example, you see it here that about a third of the death were, if I recall correctly, I made some calculations. I thought about a third of the death were stillbirth. So they disproportionately have more stillbirth compared to, let's say, us in the US and other high-income settings. And this is in part because resuscitation may be more difficult, and many times they undercode neonatal death and overcode stillbirth. So this is a very important analysis here that everyone should be understand. And when you're analyzing data from low resource settings, you also want about neonatal death, you also want to look at stillbirth because they may be, neonatal death may be coded as fresh stillbirth or stillbirth.
Yeah, thank you. Dr. Job, you have any comments on the results?
Yeah, in another table, they have some outcomes that are also interesting. There was a difference in severe respiratory distress at 24 hours, which would be consistent with the hypothesis that steroids are actually decreasing RDS.
Yeah, that slide's coming.
Yeah.
There was also better transition, which is also consistent with other observations about antenatal steroids. So I think that's all, positive.
The other thing to comment is that they got pretty close to the real results in their estimation of mortality or neonatal death in the control intervention groups. They got pretty close. Many times it's so hard to estimate because it depends on the proportion of the different gestational ages included in the trial. So they got, they had said about 25 going to 21.5% or something like that. And they were pretty close in their estimates.
Thank you. Alina, you can proceed.
Okay, and then the maternal infection, we already, there was a non-inferiority hypothesis, so it's not inferior. And this is like I found this in the supplemental material. So they did like another secondary outcomes, and that we cannot already describe it, that there was a decrease on a respiratory distress syndrome, and also they noticed that also there was a decreased risk of other. So for secondary maternal and neonatal outcomes, here I'm going just to highlight the significant and interesting results. There was a reduction of early death in the dexamethasone group. There was a reduction in severe respiratory distress at 24 hours after birth, and there was a reduction of hypoglycemia at 6 hours after birth. And there was no significant difference between groups in the incidence of serious adverse events. So now I would like to compare the ACT trial and the WHO trial. So in summary, the ACT trial, the population were infants with a birth weight less than the 5th percentile, and this was a proxy for preterm birth. Also in the design was a cluster randomized control trial. And we already kind of talked about this, but the hospital settings were different. And for the AC trial, include all level of cares. And this include some places that the resources for neonatal care were not adequate. So the sites could be as clinic, health center, and other non-hospital facilities. And for the intervention group for this trial, most deliveries were attended by a nurse in a non-hospital facility. I found interesting that among women who deliver with babies less than the 5th percentile for birth weight, 45% in the intervention group received at least one dose of antenatal corticosteroids, and only 16% of the women in the intervention group went on to deliver preterm. So this could indicate there was maybe an inaccurate assessment of gestational age, especially when you use LPM. Also, when you assess gestational age by uterine fundal height, and also could be a lack of clinical expertise in assess the risk of imminent delivery. The WHO trial, the one we described this afternoon, the population were women at risk for preterm birth based on an ultrasound and OB assessment. The hospital assessment was a minimum standard of obstetric care and neonatal care, including access to oxygen and CPAP. Sorry about the speaker, I'm on service right now. And 90% of the infants who were exposed to dexamethasone were born preterm. So that tells you that we have a more accurate gestational age by ultrasound, and we have more, a better OB care. For the ACT trial, and the neonatal mortality was, they conclude that for every 25 women, they will, okay, so for every 1,000 women exposed to antenatal corticosteroids, an excess of 3.5 neonatal deaths occur. And additionally, there was an increased risk of maternal mortality, but the population was different compared with the WHO trial, that they conclude that 25 women will need to be treated for dexamethasone to prevent one neonatal death.
Just one comment. These two trials also use different drugs. The WHO trial used dexamethasone, and all of you probably in the US and in Europe are using betamethasone as celestone, which is this white flocculent, you can tell one from the other just by looking. So for the ACT trial, we tried for about 3 years to get a preparation of betamethasone made available for use in India and Pakistan, and failed because it's so hard to get these drugs into a country where they're not already available. So the optimum comparison would have been betamethasone, as that's actually the standard of care in most high resource environments now. And this trial, both these trials use dexamethasone because it's cheap, available, and you have to be really careful with drugs when you're working in low resource environments. And just as a comment, for the ACT trial, one of the sites in India was actually using a product that they bought that had no drug in it. So it was bad product. And we only found that out by assaying the various products from the different sites. So you have to be really careful when you're doing these trials in low resource environments. Wally, any comments?
You're totally correct, Alan. We assume that we have a drug and that it should have the expected dose that you're trying to give. And we were surprised that, but noticed the problem early. So we were surprised, but noticed the problem early and stop using that medication. But we cannot just assume and that the medication is obtained from different sources will be the same.
Okay, so let's answer these questions. Were the effect of the intervention report comprehensively? They did a power, so was a power calculation undertaken? And yes. And what outcome were measured and were they clearly specified? So we already discussed that the primary outcome was neonatal death and stillbirth or neonatal death, and also a composite of possible maternal bacterial infection. And then how were the results expressed? So we explained that the dexamethasone group was compared with the placebo for the primary outcome with the use of relative risk and 95% confidence interval. And so were the results reported for each outcome in each study group at each follow-up interval? Yes. Was there any missing or incomplete data? No. Was there a differential dropout between the study group that could affect the results? No, the loss to follow-up was minimal. And were there any potential of bias identified? I did not identify any potential bias. So important question is, do the benefits of the experimental intervention outweighs the harm and cost? So for the primary outcome, there was a reduction in the neonatal mortality in the dexamethasone group compared with placebo. And there were no harm or unintended effects reported for each study group. And they did not do a cost-effective analysis. So another important question is, can the results be applied to your local population? This is more like external validity. Well, this is different because we are in the US and we are not in a low resource country, but we use antenatal corticosteroid routinely in the places that I practice.
So Dr. Job, a good comment would be made because we know the care in the low resource country is not equal. Like the basic criteria was you should have a basic level of neonatal care, but as we know that just a few kilometers away, the care can be very differently delivered in those settings. So what's your comment on using dexamethasone in those where the resource is really low that you don't even have the basic care?
Well,
should we rely on the previous studies results?
I mean, I think the New England Journal article from WHO is oversold. They basically say that this trial proves that you can use steroids in low resource environments. But as we sort of mentioned when we started this, the problem is that they did it in environments where they'd already upgraded neonatal and OB care far above what it is at the baseline in many of these environments. And so the ACT trial tried to address a different question. Can you really assess these women accurately and get them treated and then get them to a place where they can have better care for the pregnancy outcome? And so that question has never been addressed. And so if anybody wants to do a massive, expensive trial, there's a trial to do a version of the ACT trial in where we're dealing with home deliveries and primary care clinics where deliveries are occurring. So the primary question really wasn't answered by the WHO trial because they upgraded the care in the hospitals. So trying to answer this basic question is actually, as we learned with the ACT trial, very difficult. And I'm not sure anybody's up to attempting that. Wally?
Yeah, it's important that in the low resource settings, up to or above 50% of the babies are born at home. So this is a very different study in which it's facility-based in level 2 and 3 institutions. So that's really not like the lowest resource settings. That question is still unanswered. And it is an important question because many of these patients, they have a very high mortality and contribute enormously to the neonatal mortality worldwide.
And so the big issue really is that there's 2 reports now in JAMA about bad outcomes in term infants delivered after getting antenatal steroids. And in these low resource environments, if we say that anybody who might be at risk of having a preterm infant needs to be treated with dexamethasone, what will happen is everybody will get treated with dexamethasone because they use these drugs like vitamins anyway in many of these environments. And then we put many of the term infants that are delivering at risk for neurodevelopmental abnormalities. So I think this is a real concern that we haven't successfully addressed. And just as a comment, the dose of dexamethasone or betamethasone that we're using is astronomically high. We have data in monkeys and in sheep that we're using way too high a dose. Just as an example, the dose of dexamethasone that was used in these trials is greater than the dose of dexamethasone they used to try to salvage COVID patients who are in the ICU. That's 20 milligrams versus 24 milligrams. So what we know now is that we're causing adrenal suppression in all these women who are getting high dose dexamethasone. The problem is we don't have any dosing studies to make clinical recommendations. And there is a trial that the WHO is now designing to test a low dose strategy. The problem is that's going to take years to complete. In the meantime, a whole bunch of babies are going to get treated and deliver at term. So I think that's another discussion for another day.
Yeah, I was surprised I didn't comment on babies when they were born ultimately. And in the ACT trial, it was not beneficial, but for those babies born late, they had a high mortality. So babies exposed to antenatal steroids when they were in preterm labor, but born later at term had a high mortality. Not just about, we're not just talking about babies born early. These are babies born at term.
But in our environment, none of those babies would probably die. So we would never see that because they would be detected somewhere or another. But in these low resource environments, most of the mortality is still in big babies.
Yeah. Alan, the last time I looked at the meta-analysis in high-income countries, they had a few of the studies reported up to term infants and delivered at term, and they had actually an increase in mortality in those infants born at term. And this is the randomized controlled trials of antenatal steroids in high-income countries. So
this is a real concern, I think. And since everything related to steroids is dose and treatment duration mediated, they're toxic drugs, we know that. And it turns out that the dose we're using and probably the duration is too long. So there's lots of ways to give less drug, which will presumably have less complications. That's all my editorial comments. That's not, we don't have the data yet to make a new recommendation about dosing.
Alina, you can proceed.
Oh, well, I have my last line. I just would like to thank Dr. Pami, who's my mentor for this presentation at Baylor, and Dr. Jane for Cincinnati Children's Hospital for their support, and finally Dr. Garcia Pras, because she's currently covering my paper while I'm presenting.
Very nice job. Thank you for doing the presentation.
Yeah. So Dr. Job and Wally, do you have any final closing comments? Where is the future of the antenatal steroid headed in both developed and developing countries? And what do the fellows need to work on?
So to me, one important comment is that antenatal steroids have also been tested in other low resource or low middle income countries, and they have shown benefit. I think this trial was aiming for a higher, for a lower income setting or lower resource settings, but they had to settle for centers that had what they call standard newborn care. So they had more resources probably than in most facilities worldwide in low resource countries. So I think the question is still has to be answered is, do antenatal steroids work in the lowest resource settings?
And time will tell. All these trials are very difficult and expensive to do. So as I said, there's a WHO trial being designed, and one of my colleagues is designing a low dose trial in Singapore. So we'll see what happens with that.
See, I have a question from audience. Dr. Joe, you may be able to answer this better. So what's the mechanism of mortality of antenatal steroids for those babies born later at term?
I don't think anybody has a good idea about that. The whole issue of infection was brought up because of the ACT trial. There was an indication that there might well be increased infection in that data set. And so that's why that was something that was emphasized. So I suppose infection's a possibility, but very few babies die in this country term babies die of infection as a primary outcome. That may well be happening in low resource environments. So that was the hypothesis from the ACT trial, that the increased infection in the big babies that were probably term who were dying after steroids was probably infection related, because we know that antenatal steroids completely screws up the white cell counts and lymphocytes in the fetus. So there are a lot of reasons why there could be increased infection.
Wally, do you have any comment? Any hypothesis why term babies are dying?
So I think the infection question could have been in the ACT trial, could have been an ascertainment bias because they knew the patients had received steroids. So I think that may explain why this study didn't show an increase in infection and the ACT did. Why babies are dying? Is that the question?
Yeah. Do you have any hypothesis why?
From what?
For the term babies dying of antenatal steroids?
No, we look very carefully and in the ACT trial, and it's more of a continuous. It's not just the bigger babies. We didn't have exaggeration ages, but we had weight. So you see it at all percentiles of weight, maybe above 10th or 15th percentile, that trend for increased mortality. So that was quite a surprise to us.
Interesting. Well, thank you, Dr. Job and Wally, for such a wonderful talk today. I think we had a lot to learn about this, and there's a lot more to do to learn about antenatal steroids. I'd really like to thank Elena to do the presentation. I hope Elena would have shown us the baby photo for it, but hopefully next time. I do want to remind everyone that last Journal Club for this season is on Friday, June 10th with Drs. Ron Kleiman and Nehal Parikh, and we'll be discussing the PDA, the notorious PDA. So that will be a fun session to join to. Please fill in the survey link for today so that we can improve the presentation further. And I thank you, all of you, for joining and supporting this initiative. Thank you so much.
Thank you. And just to thank Alan also for, I think he may have stepped down, but his very thoughtful comments.
We all love Alan Joe.
Yes. Thank you.
Thank you, everyone.
Bye, everyone.